Right. Good evening, everyone. Thanks for joining on this late hour on a October evening. It's getting a bit cold now. So I'm going to give a very rough overview of some paediatric point of care ultrasounds, and I'm going to do it by I'm just going to go through some cases. We've had a few sessions so far, so I'm not going to go into too much detail always about how to get certain images. So this want to really show you some ways in which we can use it, but this is by no means exhaustive, and I'm not an expert. But I'm currently a PEM registrar at the Royal London. I started there in February this year, and I've been getting a little bit of coaching from one of the consultants there, and also the paediatric radiology team upstairs. That's been really helpful. And if you have any questions as we go, just please stop me and ask. Mike will be moderating, but feel free to chip in via voice or put it in the chat and just stop as we go. I think that's probably the best thing to go. So, and I'm new to Prezi, so if it all goes wrong, I apologise. So, before we do any point of care ultrasounds, it's similar with adults and children. We've got to think about, are our intentions good? So we're doing this for a good reason, or we're just having a little mess around. But usually I think our intentions are pretty good. You know, we're medical professionals, pretty noble. And with any point of care, we've got to think about our principles. So just ask yourself what you're looking for. So determine your question before you start the scan, and think about things like the pretest probability. And also think about, could it possibly change the management? Usually yes. And we're dealing with children, so keep it fun. Kids love to get involved with looking at the screen. A bit of colour Doppler always goes a long way. And yeah, that's about it there. So let's go into some cases. So I'm going to talk about a few cases. A couple of breathless kids, limping toddler, kid with a painful tummy, maybe a bit of foreign bodies. There's so much more we could cover. Kind of hurt my head when I was doing the presentation about all the things we could go over. So I'm just going to go over a few cases. And if you're not sure about how we get certain images, just please stop me. Or if you're not sure what we're looking at, again, stop me again. And kids often look like this. You walk in with that machine, they give you that look, they look at their mum, their eyes start welling up. So we've got to be nice and fun. So bit of lung ultrasound to start with, because lung is pretty useful in children. So here we've got a 16-month-old. Sounds like they're a bit bronchi. They've had a fever, but it's going on for a few more days than we expect now. Had a cough, some going, and their appetite's been a bit not so great. But they seem to get better on like day 5 of illness on the weekend. But then day 7, they had a bit of deterioration, and their parents brought them to the ED. And they were brought right around to resus because they had quite marked work of breathing and low sats, particularly low when they were lying on their left-hand side. And the SHO that saw him felt that they had some reduced breath sounds on the right side. Now, sometimes that could be because they're a bit tight with wheeze, but they didn't think there was any wheeze at all. So I had a look with them. And as you know, it's quite difficult to get portable x-rays with any urgency usually, and our resus for the children's area is a slightly tricky layout. So we did a point of care ultrasound, a lung ultrasound. Now just to cover kind of when we do lung ultrasounds, what we use, just thinking about the probe selection. So little ones, so with the lung ultrasound adults, we often use the curved linear probe and we want to look beyond the pleura. But for little ones, often we can use a linear probe because it's got enough depth to get through to the other side of their chests. And you want to tend to have a lungs preset if you can, to look for those B lines, those pleural changes. But don't forget, when you see things like you think you've got some consolidation, pop on that abdominal preset because that'll make it look much clearer. Let me just move this out of the way. Okay, so let's move on. So I've nicked this out of PoCUS 101. There's loads of these things that have gone around, especially with COVID. So everyone's getting copper lung ultrasound now. There's a few different techniques. There's a 14-point technique. There's a 12-point technique. I think as long as you know where you're putting the probe and you can describe it, we tend to go in a vertical plane, so the marker's facing up. That's great. And just try to remember to put markers when you save your images on your probe. So we did some pictures of our little one. Here's a still image. So just to show you what we're looking at. Can you see my pointer?
Yep.
Yeah, great. Yep. So here's the rib. There's a rib. There's a rib shadow. Here's the pleural line here. Okay. Here's the pleural line here. Rib shadow. Here's normal pleura. There's a nice little A line there. And there's probably a starting normal pleura here. And then we get this small consolidation just coming here. And behind it is a B line. And if I just move to the next image. So here's a little cine loop. So you can see as the child's breathing out, we've got a nice normal line here. And as they're breathing, here comes this little bit of small consolidation. Now, I'm not going to show you the rest of their lung ultrasound because the rest of it was all normal. So we just had a focal small consolidation on the right side of their lung. And remind you, it's a child who had a week's history of cough, fever, sounded like they're a bit bronchi. But in the context of having unilateral ultrasound changes and deterioration with high fever and high respiratory rate, we concluded that maybe this could be a superadded infection, with a pneumonia. So thinking about lung ultrasound, this could well be a pneumonia. You can see it's coming in here, see these B lines coming off. Look at the left side there, you see this normal A profile coming down. We've got these rib shadows, okay? And you can see that the footprint is nice and straight, so that's the linear probe that we're using. And again, one more image, so load up, there we go. I think that's the same one actually. So, I mean, we haven't changed our practice yet, so we're still getting x-rays, and here's the child's x-ray, and you can see this right middle lobe pneumonia there, just setting out the pleura. Small caveat here, those that don't do much lung ultrasound, obviously, ultrasound's really bad at penetrating through air, so if the infection doesn't go out towards the peripheries, so to the edge to the pleura, we're not going to see anything. Great. So, did this really change anything? Did this change our management? Well, you might say not, but in the case of this child, it expedited their antibiotics. It expedited the review by the admitting paediatric team, and it was quite enjoyable from a teaching point of view. So I taught the two paediatric SHOs at the time how to perform a lung ultrasound and to see pathology in action, as it were. So as well as it slightly changing management, it does really help with kind of the dynamic in the department. It makes the parents think that you're doing something, and you can actually show them the pictures and they can see what's going on, and the child did very well in it. So anyone got any questions about that so far? Just holler if you do.
Yes, a great case, Dom. I mean, even though in that case, the findings were clear on the chest x-ray, they may not always be. Sometimes
exactly.
Lung ultrasound may be more sensitive and may pick up stuff that isn't visible on the chest x-ray.
Exactly.
There's a question from Yukiko. Where on the little one's chest did you put the probe in this case?
Yeah, so let's go back a bit. If you look at this image here, so I did actually mark it, put a little marker on. You can see just up here, it's just hiding on the thing. I wrote R4, it's actually more like R3. Oh, yes. So it was up in their axilla somewhere. I just think I left the old marker on there from the other image. You have to be quite on the ball to kind of change the numbers around each time. Yeah,
and then follow up, like, would you look in each intercostal space if they are so small?
Yeah, so you do a kind of a lawnmower technique where you just look all the way around all spaces. You can do single points, but they're quite small. It's quite easy, and just sweep around, and you can do it pretty quickly in a few minutes. Just have a look all the way around, and the kids tend to be, if they're poorly, they're pretty compliant, and it's quite obvious when it's normal lung sign, normal pleura. The more you do it, the more you'll get used to what's normal. In, say, your bronchiolitis kids, they might get a kind of viral pneumonitis type picture, so they get a few B lines here and there. But if you've got isolated B lines and with a small consolidation in one area, that might be more convincing for a small pneumonia there. Any other questions?
No, that was great. Nice.
Great. Okay. So we've got another one. You guys may have seen this if you look at Angus's blog. under the helipad. So don't spoil it if you have seen it. But here we go. So we've got a 14-year-old boy. He's a known asthmatic. And at Strebe, the nurses asked for a chest assessment because he seemed quite breathless. And the SHO was very diligent, went around, had listened to their chest, thought it felt pretty quiet, but it's quite hard, they're still clothed, try and have a listen to, is there wheezes or not? So because they're working breathing, they brought them around to resus. And I overheard them talking about the case as they were bringing them around. So I went around with them. And he was obviously in a lot of distress. He was really breathless. And it was quite quick onset. And he'd been getting this chest pain on and off the past few months. But at the time, all we heard was he had chest pain and breathless. And he was tripoding in the bed. And there were no breath sounds whatsoever on that right side. So obvious diagnosis is clear, isn't it? This isn't pneumothorax. Or is it? So here is his right lung. Here's his left lung. So this is nice and normal. So we've got the probes going in the first zone, so just in the mid clavicular line, and you can see there's nice lung sliding. So there's the rib shadow. This is the pleural line going up and down. So the pleural line is always deep to the rib shadow. So it's not a line above it. It's not a line up here. It's always deep to the rib shadow. So always get rib to have your orientation. And you can see a nice A profile. So these reverberations of the pleural line coming down. Okay, and these nice little cocktails. Now, if you look at its right side, if you look at that really quickly, you can see there's no lung sliding. So here's rib shadow. Here's the pleural line. If you weren't paying attention, you'd say, okay, no lung sliding, pneumothorax. But if you look a bit harder, you can see that black area here. So this could be pleural thickening, or it could be a bit of pleural fluid there. So it's probably a bit of fluid. And if you look in the far fields here, this almost looks like liver, it looks tissue-like, doesn't it? Kind of this mixed heterogeneity. So it's like, hang on a second, doesn't quite was expecting. So what do we do? So I did zoom there, so you can see a bit closer. So there's a rib shadow. Here's the pleural line. There's probably some fluid, and you can see this mixed heterogeneity of the pleural there, of the where there should be air, lung, this kind of mass, solid. So it could be infection, could it be collapse, could it be something more sinister? And while I'm scanning, the SHO is getting more history from the child. So what do we do? Turn your depth down. So turn the depth down. In a second, it should load. Yep, there we go. Turn that down, nice big rib shadow. There's the pleural line. You see I've got a curved linear probe here rather than linear probe before. And still this massive tissue-like thing. What we're looking for is maybe some air bronchograms, like dynamic air bronchograms. That's when you see, I think it's been spoken about on previous presentations, where you get this movement of stuff going through the airways, but can't really see anything there. So turn the depth down even more. And again, you see this large kind of mass-like structure. Don't really know what it is. Again, I'm still thinking, could this be infection? Don't really know. And this is in daylight hours. We're very privileged where I work because we do have paediatric radiologists. But this kid was sick. He was sat on the edge of the bed. He could not lie flat. And the story transpires that he's been in intermittent chest pain for the past 6 months and getting a bit more breathless over the past few weeks or so. But had no B symptoms, nothing else to make us think lymphoma. But I thought, okay, so if this could be a mass, let us just move the ultrasound around, have a look at his heart. And I'm not really going to talk about echo today, but I just want to show you this this view. So this is a parasternal long-axis view, and I've just taken a short clip of it. So over here is our apex. There's the tip of the right ventricular outflow tract coming through here. This is the left ventricle. This is the left atrium. Mitral valve is just opening, closing there. Here's the aortic valve, and this is the aorta coming out here, okay? This here is probably one of your pulmonary arteries. You don't normally see this because you've got all this tissue-like mass surrounding the aorta there. I didn't really know what it was. I assumed it was probably lymph nodes, but I mean, this is getting way beyond my expertise at this point. But I knew this kid was sick. He's got this mass-like structure in his right hemithorax, and it's all surrounding his aorta. You don't normally see the structure here. So what do we do? Well, we asked an X-ray. That took a little while to happen, but also spoke to the paediatric radiologist who kindly did a formal lung ultrasound. And this really changes management, because if you had a look at his X-ray, I'll show you here, you might think that this could be a massive pleural effusion. If you hadn't done an ultrasound, you see there's a shift of the mediastinum to the left. The rib spaces are getting bigger, so everything's kind of being pushed across. And there is like air shadow there. So if you're smart, you might think about, I'd probably say, oh, that's definitely fusion, just to put a needle in. We wouldn't ever do that, obviously. But if somebody's such extremists, you might be pushed and you might think about doing that. So I think doing ultrasound in this case really changed the management because we didn't do anything too gung-ho. And we managed to get a radiologist to do a proper scan. And it was really suspicious for a sarcoma. So he got transferred to our quaternary oncology centre for PICU there. He's actually doing all right at the moment. But yeah, an interesting case where ultrasound really changed management, lung ultrasound, and it wasn't what we expected. It wasn't pneumothorax, even though it was a tall, skinny young man who can fit the bill. So has anyone got any questions about that or how we did it, or haven't got any idea what I'm talking about?
Another brilliant case, Dom. Yeah, I totally agree. Like on the chest X-ray, that I would have also said looks like an effusion.
Yeah.
So yeah, great.
Okay. So that's the bit of lines I'm going to do. I'm not going to go too in depth about anything really. But if you do have questions, I'll do my best to ask. I know there's a few other people who's on the talk who on the Zoom that I might deflect to, but we'll see. So let's look at a limping toddler. Another great, look at this GIF. That's a great one, isn't it? So this is quite a classic presentation. You've got your 2-year-olds. They've been a bit grumbly at home, bit of a fever. They've woken up this morning. They're not putting any weight on the leg on the left side. Don't think there's any history of trauma. The obs are pretty normal, but they are really pissed when you try and examine their leg. And you do an X-ray, and it's normal. You do a hip X-ray, or you might be thinking, could it be a toddler's fracture? There's any indication of that? All normal. Okay. Even had a case once where the kid refused to have an X-ray, had the same ultrasound features that I'll show you later. That's how pissed she was. Okay, so here we're going to talk about doing hip ultrasound. So I'm not talking about doing ultrasound looking for fractures. I don't do that much, but I know lots of people do it. And I do it just out of interest, but it's just not in our kind of SOPs yet, but that's another thing to cover at some point. So thinking about the probe, so linear probe tends to be best because they're small enough. So you've got footprints big enough. You don't need that much depth. So 5 centimeters should be fine. But if they're a large child, if they're overweight or they've got adipose tissue in that area, you might want a curvilinear probe. Just put it on an MSK setting, that'd be fine. Okay. So where are you going to put your probe? So I've shown this image from ASEP. They've got some really good stuff on how to, a couple of kind of pediatric things like hips, foreign bodies, and some appendix stuff. But where are you going to put your probe? So your marker's going to go up to your linear probe, marker's going up towards the belly. You're going right up to the groin. Often it's quite medial, and you want to be perpendicular to the bone. So what you're going to hit with your ultrasound beam is the neck of femur, and you're going to see the epiphysis and the capsule there. Okay, it's actually a really easy scan to do, and it's really satisfying. So these images aren't the best images I've got. I've got some better ones, but this is my most recent case. So this is their right hip, so I've labeled it. Very good. And here is this patient was slightly larger. Here's all kind of tissue, some fascia. This white line here, this hyperechoic line here, that's the neck of femur, and you can see, okay, round the head. Here's the epiphysis here. Here's the joint capsule, and this is normal fluids. Okay. Whereas we look at her left side, again, here's the neck of femur. So it's hyperechoic, it's white. You can't see behind it because ultrasound flecks of bone was absorbed. Here, you just see the neck, you just see the head of the femur. Can't quite see it here, but normally you might get a nice epiphysis here. And you see this biconcave swelling, and you can see it's 97 mils, and you're measuring outer to outer if you can. Some people do it inner to inner, but the way I've looked is outer to outer. Okay, so if you can compare this again, you see it's nice thin line. here it's a real bulge. So what's significant? So the Americans say more than 5 mils tend to be significant, but ideally you always want to compare both sides because there's normal variation. So I tend to say if it's more than 2 mils difference, that is significant. So more than 2 mils difference between the asymptomatic side. Obviously, you can get bilateral transient synovitis. Just take all the clinical picture. But just be careful. So this is all cartilage here. So cartilage can look quite hypoechoic, so black. So don't measure around here. Always measure here, which is the joint capsule. Okay. So true effusion is going to cross all the way down. All right. Don't put too much pressure on. If you put too much pressure on, you might just, like we occlude a vessel, you just squish it all down. If it's a really infected joint, so if it's really putty, that fluid might not be as black, so it might not be as hypoechoic, so down. So if it's pussy, it might be a bit more kind of echogenic, so a bit whiter, more speckly. All right, so that's why it's really important to measure the size. But what does this all mean? What we're going to do with this all? So limping child, we should probably consider the PoCUS criteria. So that's for evaluating if we think there could be a septic joint. So do they have a fever? They need some blood tests, and can they put any weight in it at all? It's not, can they kind of be limping? If they can't put any weight in it, fine. So this kid could put any weight on it. They didn't have a fever there, so their PoCUS was 1. Had some blood tests, and their white cells were up. So we got orthopedics to come and see them. It's difficult because the scan cannot differentiate the transient synovitis from a septic arthritis because we're always worried about that. And really, we leave that to the orthopodist to decide whether they're going to do an aspiration or not. But it's really, really satisfying thing to do because at least you can work out why the kid's limping. Sometimes those kids, you don't know why they're limping. You can't really work it out. Have a little scan, you find a bit of fluid. Okay, but as I said, ultrasound's also really good for looking at fractures, but I didn't got any saved images of cases, so I didn't want to make it up. Cool. So anyone got any questions about hips, limping kids?
Yeah, feel free to just unmute yourself and shout out if anyone has any questions. Yeah, really nice case again, Dom. Yeah, I think it sort of illustrates one of the sort of truths of PoCUS, how it's a lot of it is just reducing diagnostic uncertainty, just reducing your differential.
Yeah, I think this recent one was my colleague you saw felt that maybe it was a thigh, wasn't really sure, did a load of x-rays, couldn't work it out, and we found it quite quickly with the with that ultrasound. So it's really rewarding actually. Just got to be careful. There's been a few times I've been a bit unsure, and the formal scans have also been a bit elusive. So, but if it's obvious spindle like that, that's quite satisfying. So don't use it as a rule out thing, especially if you don't have the right governance or people around you to help you out.
Yep.
Okay, good. So we're making some pretty good progress here actually. So I'll try to slow down a bit. Right, let's go on to hurty tummies. So we're going to do some abdominal scan. Talk about abdominal scans because kids are always coming with tummy pain, and things like appendicitis are notoriously difficult in children. They don't always present with those classical features, and little babies, they don't tell you what's wrong with them. They're just a bit now. I think the thing to note is just got to be careful with, especially kid scanning, but with abdominal stuff, it is quite specialist. That's why we've got paediatric pathologists, but it's got great potential. So it's useful in our adjunct, like with the hip one, to our clinical picture examinations, so looking for appendicitis, looking for a pyloric stenosis. I haven't got my own one yet, so I've not made an image about it, but I've seen a couple so far. Intersection, really useful. Looking for free fluid. Be a bit careful with free fluid because when kids have got a bit of a tummy upset, they can have little bits of fluid upset, fluid in the just physiological fluids with normally or the gastroenteritis. So just be careful with that. Obstruction. I think we've had a case before with forward backflow and things like hydronephrosis. Spell that wrong. Good. Okay. There's loads and loads of possibilities. I'm just going to cover a couple of them in this talk. So we're going to talk about big donuts. So hopefully you all know what we're going to be talking about. And I won't spoil it yet, but it should be pretty obvious. Homer loves donuts. So we've got two cases side by side. So first is 17-month-old who's had 2 or 3 days of vomiting, got seen at another hospital, was observed in the observation unit, passed fluid challenge, well discharged, then came back because the vomit got a bit greener, so they were safe knitted. Green vomit is never a good thing in anyone, and they were getting some bloody streaks of stool. And a week prior, they had kind of some chiral symptoms, a bit of a cough. So I'm guessing everyone can be thinking where we're going now. And within the same week, there was a 3-month-old who had 4 days of vomiting. Parents think that they were sore in the tummy, they're drawing out the knees a bit. And this all happened 3 days after they had their rotavirus vaccine. But this 3-month-old looked pretty poorly. So they were transfer in with an unclear diagnosis to our ED, but they look rough. So they're two similar but quite different cases. Now, if you haven't guessed already, we're talking about interception. So why cough and coryza is pertinent, why the rotavirus is pertinent is we know that it can be a post-inflammatory thing, so you'll get your Peyer's patches that inflame up, which is a lead point for interception to happen. And there's some case reports that rotavirus can slightly increase your risk of interception as well. So probe, linear probe is generally fine because they're small children. So your abdominal preset and just have a good search around. So I've nicked this image from the Brown EM blog. You can see it's nice square in this abdomen. It's basically following around the large bowel. Just imagine how the large bowel is going around. But all you're going to do is just scan around and just look for anything that looks abnormal. When you find something normal, you're going to rotate your probe to see if you can get this donut sign. All right, but all the way around and just basically just normal around the abdomen. That tends to be what I do. And they say in expert hands, it's 100% sensitive and 100% specific. Obviously, we're not experts at this, but some studies looking at EM trained physicians that have only had an hour of training, the sensitivities have been in the 90s. So that's pretty good. So look at the donuts. This is case 1. So you can see this is a still. Let me get you the silhouette. So here we've got a nice donut. So a nice rubber ring on the outside, filled up with some nice jam in the middle. This is a classical picture we get with interception. So you get basically the large bowels evacuating from itself at a leader point. And then our other child, who was a bit poor, a bit sicker, a bit more unwell. Again, you can see the bowels really thick here. Here's the interception. Quite a lot of free fluid coming around. So there's free fluid around the wall, also free fluids in the abdomen. And this one went all the way around the abdomen. It was everywhere. So unlike the other child, it was just a small point in the left fossa. This was everywhere, and you could feel it. It was really impressive. Quite a bit of free fluid as well. And again, as it's around the abdomen, there's free fluids everywhere. So how are they different? So 1-month-old was, the 17-month-old was pretty standard, bog standards, the surgeon would say. They were quite well, didn't need resuscitation, and they had an insufflation enema, which worked great. The 3-month-old, it was in the middle of the night. They were pretty sick. They had 5 fluid boluses, which made us all a bit nervous. So did regular lung ultrasounds, which were nice and clear, no B-lines to make us think that they were getting a bit wet. But they were bringing out loads of green stuff, and they were pretty hemodynamically unstable. So we took them to theatre because they had a lot of their gut there, which is, you can probably tell, but they did really well as well. How did it change management? Well, everything got expedited. So the first case, did the scan straight away. The surgeons were up from their ward round. They were going to see them later. But they're like, okay, if it's that bundle, we'll come see them now. They like to get a proper departmental ultrasound, which is right. Confirmed it, and they had the installation enema within a few hours. The second case, and as the kid was a pretty child, we got pretty sick. We got the radiologist to come in out of hours and do the scan in the department. And it was also useful doing the lung ultrasound just as we were resuscitating them to make sure they weren't getting more wet and more well. But this is one of my favorite interceptions, one of my it's really enjoyable when you pick it up. And it can be really hard for those small babies who are just a bit cry, a bit ouchy. You think they've got tummy pain, they've had a bit of vomiting, and it's quite a nice thing to do as a rule in, because if it's there, it's there. Any questions about interception at all?
Yeah, another fantastic case, John. So for the second case where the pediatric radiologist came in,
yeah,
like, would you have been able, if you'd been able to show them your images, do you think they would have been happy with that? Or?
Yeah, they were pretty convinced. I think the question there was, they got their consultant to come in because they want to kind of have a joint discussion with the surgeons about whether this kid, if they wanted to risk trying insufflation enema.
Oh, yeah.
And they wanted to just double check that it was how extensive it was. Mm-hmm. So that's where they got their boss in to double check, because I can't check it. I can say it's there, and it looked like it was everywhere, but I didn't really know how to interpret that really in terms of next steps. So that was why. Yeah,
fantastic cases. Yeah, and as you say, just expediting the care in itself can sometimes be really important with these cases.
Yeah, and I think that's the most important thing in most of the cases I'm talking about. And a lot of PoCUS, it changes the pathway of a patient. Like the child who had the mediastinal mass, it really changed their pathway from quite early on. And that's one of the things why I love ultrasound. Right, so let's go to the next case, unless anyone feel free just to chip in if you want to stop. So the appendix. I'm not a big fan of the appendix. I always struggle to find it. But here we go. So we've got a 4-year-old boy who's been referred in. So a lot of the children that come in from other hospitals come via ED if they're a bit unwell, especially if there's not a bed on the ward, or if the surgeons aren't sure and they think they might send them back. So it means we can often see them first or concurrently if they're poorly. So they were referred in as a career obstruction. They've been constipated for about a week and were seen elsewhere with some tummy pain. They were treated some laxatives, which worked. He started pooing loads, but his tummy pain didn't really settle. Got more unwell and started vomiting quite a bit, and then started bringing out mushy peas, proper like green bilious from it. So I was admitted the day prior at the local hospital and found to have a very high CRP and inflammatory markers. So this is pretty classic. You know, kids, as I said, they're so hard to know if they got an appendix or not, and it's probably why surgeons get a lot of referrals to speed appendix. But ultrasound does help them, and it may help us in the future differentiate these children. Anyway, sorry to see him. Before I do that, obviously, how do we find it? It is really hard. Again, this is from ACET. There's a really good article about ACET, but you can have all the links, just write these links down. But the idea is you pop the probe transverse at the umbilicus. So start here, then you slowly move your probe more lateral towards the colon. And once you hit the colon, you come down a bit, and then you come across, CD identify the psoas, the iliacs, and the appendix should be a blind ending structure hanging around here. But often you've got to rotate your probe a bit. You've got to spend a little while looking around. Often the easiest thing to do if the kid saw is just point on the point of maximal tenderness. But often you've got to change your axis quite a bit, and just use your landmarks. If you can find the psoas muscle, often it sits anterior to that. But again, it can be quite tricky, especially if it's normal. But it's more useful in children than adults because children tend to be thinner. They've got less adipose tissue. So that's probably why it's more uptake children. So again, I saw this image from ACET. So this is what you want to see. You want to see this blind ending structure with this nice hyperechoic line going through the middle. Okay. And here's the psoas just lying on top. But as we know, appendix can be sitting everywhere, flopping back, forwards, left, right. So it's not always as easy as it looks. But when we do find it, if we find it that view, we want to rotate our probe. So going transverse. And if it's more than 6 mils, that tends to be abnormal. So if we saw something like this, you can see there's edema going around it. Here's the center of the appendix, and you measure from outside to outside, more than 6 mils. That's probably abnormal, and that would easily buy you a surgical referral. That's probably appendicitis. And you can also see around it, you see all this hyperechoic fat. You don't usually see this in the bowels. This is abnormal as well. This is localized inflammation. And there's a bit of fluid just sitting around as well. So you've got to do quite a few kind of abdominal scans, appendix scans, to work out what's normal and what's not, because it can be quite tricky. But other things to talk about looking for, so looking for free fluids, the ring of fire. So that's if you put color Doppler on, usually bowel wall doesn't have much blood flow going around, but an inflamed appendix looks like a ring of fire because there's all this flow going around. Inflamed fat, as I've showed you, or appendicular, so a small white hyperechoic structure with often an acoustic shadow behind it. And that means you've got an increased risk of perforation as well if you see one of those even in normal appendix. So often you're looking for other signs if you can't find the appendix. So this kid, he was really sore, so I didn't want to play around too much. I sort of see if there was anything barnder or obvious. Now, I'm not 100% sure if this is the appendix or not. I saw this first. It seems to be blind ending, but I haven't got you the other views. And it's 6 centimeters, bit of free fluid around, but I can see there's some free fluid. And as I had another little look around, you can see this hyperechoic fat here. It's free fluid. This is the bladder wall just here. All looks a bit mucky. And again, this big pouch of free fluid just sat here. And he was like, he'd been given some morphine. He wanted some mummy. He was really hungry. He wanted something to drink. So I stopped it there because, you know, it's point of care. We don't need to find the exact image in this kind of case. But what we did, I called the paediatric radiologist to say, can you find this? Can you find it for us? And they did. So they confirmed that it was appendicitis with a perforation and appendicular and a collection. I wonder if this just here might be the appendicular just there that was stuck at the base of the appendix. I think it probably is. So again, his care was expedited. He went straight to theatre. Had to have a little bit bowel resected, but it's not very well since being discharged. So I think the appendix is tricky. I find it very difficult. I don't scan every child that's got abdominal pain. The only reason I do it is to try and find the appendix if I think it could be more differentials. But it is practice, and if you do have a paediatric radiology department to go or just follow these kids when they go for ultrasound, it's always good just to get tips from them just to help, because it's a real tricky one. Yeah. Any questions about that one?
Yeah, another brilliant case, Tom. So hit after hit. Sounds like you've got a really good relationship with your radiology department as well. Like,
yeah, they're pretty nice. They're pretty flexible. I can't.
They respect your, like, when you tell them your findings, they respect that and they take it on board.
They're not that bothered. They take it on board, but they're going to do it anyway. So they're interested, but also they've got a lot of trainees themselves, so they're quite focused on training their own radiology trainees. So they're really nice, and they help us. They're happy for us to do these scans, and I tend to save them onto images that I can attach to the notes. Well, I can't actually put them on packs that I trust. But yeah, they're not against it, shall we say?
Yeah, it's so important, because obviously there are some radiologists who are quite skeptical of these point of care scans, and yeah, I think having a good relationship with radiology is really key. So
yeah. And obviously in that kid, if I couldn't see anything else and I thought it was normal, you still wouldn't send them home, because they've got a lot of tummy pain. They're pretty poorly. So just, you're not always going to find something. Obviously, these are my hits. I've not shown you all my duds. Right, there's not much more. Let's see what we've got next. All right, yeah. So I think this is one of the final bits. So a bit about foreign bodies. Splinter, who remembers Teenage Ninja Mutant Turtles?
Yeah, totally.
So foreign bodies have always a bit of a nightmare. child stepped on something, and let's say if it hurts. X-ray is pretty inconclusive, but ultrasound is pretty useful. So glass tends to show up as a little hyper, so a white streak. And wood, you often see a kind of an acoustic shadow. Often, if they're small, you often can't see much. So you see a little streak or a little shadow. But this is a little bit of planning or thinking before you jump in and pop the probe straight on the skin. So you need to make sure that you can focus on the object in question. So what do I mean by that? So linear probes are perfect for this because often it's going to be quite superficial. So you want a high frequency. If you can adjust your focus, adjust it, bring it down as into the near field as can, because you want to direct that ultrasound beam onto something in question. And you need an acoustic window. So what do I mean by an acoustic window? I mean something like this. I don't do this. This is not what I do. I'll show you what I do in a second. But you want to have a window because if something's in too much the near field, the beam won't be able to differentiate all these tiny objects that are right by the probe. So you need to make a window. Now there's ways to make a window. You can use back fluids. You can get a glove, nice warm glove, fill it with some warm fluid, fill it with water, and put it on the part in question. But often feet's end of limb is quite easy to manipulate. So I like to use a water bath. So just get a sick bowl, pop their foot in the bath, nice warm water. Because I don't mind it. It's quite nice to have a hot warm bath and it's soothing for their sore foot. And you could use loads and loads of jelly, but you're wasting loads of jelly. And you're just looking around, just staying about a centimetre or two from the skin and just panning around, changing the angle of your probe to see if you see any of these hyperechoic structures or these acoustic shadows. Once you find it, then you can get a little needle and fish it out. So this was a young girl I saw a while ago now. I think this is March time. They were sure shut a piece of glass. The X-ray, you couldn't really make anything out. Did the ultrasound initially, forgot to put an acoustic window on, couldn't see anything. I was like, well, sure something's in there. And I was like, there's no acoustic window. So you can see this water bath. So all this black stuff was hyperechoic, that's just water. And you can see this little hyperechoic white shard there. So what we do, put some LMX on, bit of local anesthetic, and popped it out. And it was tiny. It's just this tiny shard of glass here at the tip of the needle. And hey presto, off she went. And I think ultrasound's great for our bodies. So that's most of the cases I'm going to show you, but there's so much more you can do. We do quite a bit of echo, not so much the complex echo, because pediatric echo is complex, and I've done a few sessions with the pediatric cardiologists. So that's a whole another talk looking for VSDs and PFOs and stuff. But in the world, this age we are right now, where we've got PIMS, TS floating around, it's really good just looking at myocardial function in those sick patients we get in resus. There's loads more soft tissue stuff, so looking at cellulitis, looking at MSK as well, but fractures, tendon injuries. I had some renal cases, but I thought it would be a bit too much. But hydronephrosis isn't that uncommon in children. Had a case last week she had abdominal pain for a week, vomiting, had been referred to surgeons. They did a departmental ultrasound, but she was a bit overweight. They only looked at the appendix and the bladder, didn't see anything, had a laparoscopy, normal, went home, came back more unwell, fevers, high CRP, and she had obstructing hydronephrosis on the right side. I went for a stent. So just always keep your blinkers open when you've got someone you think you know what's going on, but just do the full ultrasound if you can. And obviously vascular access is useful in the bigger kids. It's less useful on really small babies because it's quite hard to hold them down and have a small enough window to look. But there's some good websites. So Angus's blog, Untitled Chapter's got a few of these cases on there. This ASEC website's really good for some appendix interception from bodies in children. And there's a brief review on by Kean McDermott on the potentials for paediatric PoCUS. I think that's about it. So I didn't want to go go too much. Finish a little bit early, but has anyone got any questions about utilities of PoCUS or in kids?
Yeah, that was such a great talk. Thanks, Tom. Really inspiring. Like, I think you really showed what an impact point-of-care ultrasound can have in pediatric emergency medicine. And I'm sure there's some people on the call who've maybe also had experiences that they might like to share. In my current job, I don't actually see kids, so this is all quite new to me. But anyone on the call have any questions, or maybe would like to share stories yourselves?
I'm happy to share.
There's a question in the chat. Any tips for trainees not in PEM regarding clinical governance and oversight of ultrasound?
Well, yeah, it's difficult, isn't it? Try and find someone that's interested. I don't know. I mean, I think if you can give it a go, just be really cautious with kind of how you interpret things. But if you're at a DGH and you're in a hospital that doesn't have a peds team, and you've got a kid who's, as in, don't have peds surgery or peds radiology, and you've got a child who's got some tummy pain, they're vomiting, or they've got some red stool. If you do your abdominal ultrasound and you see interception there, I mean, it's not going to be much else than the donut sign. I mean, it could be a massive appendix, but it's something that needs pediatric surgeons, isn't it? So I think clinical governance is really important, but I don't think it does, and it won't do the children any harm, if that makes sense. But just yeah.
Yeah, I think as you say, if you use it wisely and you're aware of your limitations, there's a program called PACTUS, right? Which is some kind of a system for pediatric PoCUS, no?
Yeah, there is, and there's an RChem pediatric PEM PoCUS workshop in a few weeks, I think. So I don't know if it's got spaces still, if you go on the RChem website. But the CATS course has been quite oversubscribed for a while, but hopefully they'll have some more courses now. But it's kind of like level 1. It's like a level 1 for ultrasounds.
Okay. But presumably there's also like a framework for logbooks and sign-offs and things through Cactus.
Yeah, I'm not sure at the moment because I haven't really got any of that myself.
Yeah, I think it is a similar structure to.
I think it's similar to level 1 from what I've read.
Yep.
And that link's the link to the presentation, I think. Oh, I showed it to one person, sorry.
Ah, cool.
Let me send it.
There's a couple of other questions in the chat. Yukiko, I think this is just a message of support. Just mentioning how in peds, obviously radiation is a bigger deal, and so therefore ultrasound has a bigger potential role.
Yeah, and I think things are gonna possibly go that way, maybe with fractures, but we're not all there yet. It's not common of use. And so it needs to be by for everyone. Yeah,
I guess CT is probably the big one, right? And out of interest, being a trauma center with pediatric radiologists, do you guys like use any contrast enhanced ultrasound as an alternative to CT for bleeding, or
not as an immediate point of care, but they do it later on because they feel that sick, they get a CT.
Yep.
How common is?
I can see.
Yeah, it's relatively common. I see it quite a bit, especially the younger ones, but only small bits. So tiny bits in the pelvis, a bit like you see in young women. And thinking of so it's all about previous probability of what your clinical context is. So if there's free fluids and you're suspicious, you've got a high previous probability that you think there's something going on in the abdomen, treat it as a positive sign. But sorry, it's a vague answer, but I'd probably get some more formal imaging at that point, or observe the patient. But when I say physiological free fluids, it's a stripe, but it's there. You can see it.
Yep. Any other comments from anyone in the audience? Mayrad, you're juggling a baby at the moment, aren't you? Do you ultrasound your baby to see if their bladder's full when they say they've already had a wee? I find that quite useful.
I'm just trying to develop an ultrasound guided sleep training program for now. So.
Oh, really?
No,
Okay.
of course not.
Okay. Cool.
No, but yeah, I don't have anything to say apart from thank you. Yeah, I think for me is the biggest bonus of using ultrasound would be just the foreign bodies when I do an ultrasound shift. It's just like phenomenal. Specifically that, as Dom mentioned, like you're not going to see any wood on any X-ray, so and all the splinters and everything. Very recently, like a couple of weeks ago, we had a child who jumped into kind of like a bushes and then had like a lot of stuff in the back of her thigh, and then she came like about 3 days later, and it was quite like embedded and deep. And I ultrasounded that we could easily see it, and we actually removed it ourselves in A&E, and it was quite satisfying. Yeah.
Yeah, absolutely. Yeah, and like you were saying, Dom, with Echo, yeah, I had a 15-year-old who the PEDS guys kind of saw me walking past with an ultrasound machine and said, "Michael, come and have a look." It was just sort of undifferentiated shock, blood pressure of like 60/20. They didn't really know what was going on, drawing up antibiotics, getting fluids, and within about 10 seconds of putting the probe on, you can just see the heart's not moving.
Yeah.
And I mean, obviously he had a formal echo later on, but just from
Yeah,
the very beginning of the journey, you know exactly what the diagnosis is. And also it actually did change immediate management in terms of not giving fluids. So yeah, there's lots of different situations where it can be super useful.
Yeah.
And yeah, the first case you had with that little consolidation, I guess in a different clinical context, that kind of sort of slightly wedge-shaped consolidation could also be like from a PE, or I actually had a sickle patient with a sickle crisis who had similar kinds of findings. So I guess like with all PoCUS, it's all about integrating it with pre-test probability, putting it in clinical context.
Yeah, it's all about that.
Oh yes, Ben's just arrived. Don't worry, it's all been recorded. I'll put it on YouTube if that's all right with you, Dom, and then we'll put the link on the Slack group. Yeah, and by the way, we've changed the name of the Slack group. Well, I just changed the name, made an executive decision. It's now the PoCUS collaboration, because we've got a few international and non-emergency medicine friends who've joined. Hopefully you're all aware of it. And there's loads of great resources on there, as well as links to these monthly sessions. Yeah, lots of messages of support. Yeah, that was a fantastic talk. Thank you, Dom.
Great, no problem.
Cool.
Cheers. End it there.
I'll put the link for next month's up on the group shortly. Thanks again, mate.
Ciao.
See you, everyone.
Bye.
Thank you. Bye.